All right, now we're going to have a presentation by Dr. Laptiste, Christine, on the impact of intangible cost of disease on our GDP. Christine is a research fellow at the HEU, another student of Carl Theodore. Her area of her research interest is in healthcare financing, poverty, and costing of diseases. Christine.
Thank you, Andrea, and good afternoon to everyone. I am going to be speaking briefly on some of the work that was done in trying to develop a model to estimate the intangible cost of illness. Our frame of reference really is end-stage renal disease patients in Trinidad and Tobago. So let me start off by just looking at what intangible costs are, and they really refer to pain, anxiety, and suffering, and the loss of the quality of life that patients who have a disease incur. So they are really the soft things that we can't easily measure, and sometimes when we look at our costing studies of disease and illness and so forth, we normally find some of the hard figures in terms of what we spend on medicine and equipment and all these sorts of things. So what Prof. Theodore actually challenged me to do, he said, I was actually looking at, the costing of disease, and he said, why don't you take a look at the intangible cost of disease and see what we can do there in terms of an approach to measuring these. So what the framework I'm going to talk about now, it develops a methodology for looking at intangible costs, and what we have done here is to link our macroeconomic theory and health utility information together in a way that enables us to look at moving towards an estimation of the intangible cost of disease. Now, what we did was to look at a cohort of end-stage renal disease patients, and essentially this was a more captive group in terms of being able to locate a group of patients, a smaller population, and which would really allow us to do a larger sample. So the approach to the model is this, essentially. We are saying when we think about our macroeconomic theory, and in particular, when we look at the whole concept of potential GDP, one of the key definitions of potential GDP is that it is a point at which all our resources are fully utilized efficiently. And our thesis here is saying that if we are to actually utilize our resources at that maximum efficient point, it means then that the resources have to operate efficiently. And in the case of labor, when we pull out labor as a resource, what we are saying is that labor in itself has to be healthy. One of the assumptions we make when we do our economic theory and so forth of the individual, and we talk about demand and supply, and we say, what are the determinants that impact the demand, how an individual will demand something. We say the price of other goods and the price of the good itself and all these different things. But there's an underlying assumption there that the person is healthy. Because to enable them to be able to do those things, we are saying then that the resources that are at hand to them are not really going to be used on paying for poor health. So our main hypothesis here is that labor, when we talk at the point of potential GDP, that labor can only be fully utilized in its most efficient capacity if labor is experiencing that perfect health state. And we link that to what Henry talked about a little while ago when we looked at the EQ5D. And that same instrument, as he indicated, we worked together a little bit in terms of looking at that, the end-stage renal disease, the dialysis patients. What I'm saying here today, too, is that although we acknowledge that labor productivity is not solely dependent on health, we acknowledge that if we are to achieve that potential output, we can't achieve it without that. So that's one of the key things that we are saying here. And we are also saying that our health states are reflective of the framework in which we operate and produce and carry on our daily activities. And it is really operating in that particular health state which gives us an indication of how we are able to generate our output. Let me go back to that point. All right. Okay, so another key point here is that we are saying if we can identify at potential GDP, that point and our assumption, we are saying that in that case, at that point, individuals must be experiencing that perfect health state. Then, when we talk about our actual GDP levels, it means then that there is some deviation away from our potential. And if we can measure that deviation in terms of GDP, then it stands to reason that we can measure that deviation when we talk about the health states of individuals. And we take off in terms of our measuring of intangible costs from that point. So what we did was to derive the health states and utility scores of ESRD, end-stage renal disease patients, as well as a matching cohort from a control group in the general population, and that was work done by Henry in the general population, and we worked on getting the health scores of those patients who were part of my study. And we make the assumption that there's no bias in the control group from the general population, and that if any person with ESRD was surveyed in this group, the impact would be minuscule. I would not go into the EQ5D questionnaire that was undertaken, so thank you for taking a couple of minutes, giving me a little extra minute, Henry. And what I would do is to look at some of the results that we got when we compared the two cohorts, the patients under dialysis treatment and the general population. So the mean EQ5D score for both populations was calculated, and these scores indicated how far both groups were away from perfect health. So we have an index from 0 to 1, where 1 is the best possible health state, 0 being the worst possible health state. And what we did is to look at the difference between the income of the control group and the income of the ESRD patient groups at their calculated health utility points. So on one hand, what we would do is to look using the EQ5D measurements. Let me skip. I did take out that. Okay, so I'm jumping ahead to go back, because this gives us an idea in terms of a little snapshot of what the index for the value of the ESRD patients and the matching cohort patients, what their health index was using the EQ5D. So we would see somebody who was saying that they had a state of 11111, that perfect health state, we have an index value for that, which was 1. And as you go through the various combinations of reported health states, we would come up with an index for that. So this was done both with both populations, the matching cohort and the ESRD population. What we also had to do in terms of approaching that estimation of intangible cost is to also look at measuring the potential income. The year that we used was 2010, and what we did was to use the HP filter to actually generate the potential income for that year. So we are setting the stage here now. We have the potential income for 2010, which we are saying will be attained if the population had perfect health. So we have the potential income for 2010. We have the index, the health index values for the matching cohort and for the cohort with under dialysis. We next also had to look at how we're going to measure the income, because when we look at per capita income, we realize that it does not consider all the distributional effects. So how do we account for that? And we use the equally distributed equivalent income method, which allows us to equate values of income for individuals across households. So what it does, it actually brings all households, regardless of the differences, and so it brings us to a common denomination. So we use an equivalent scale, and we transform our regular heterogeneous population into a population of equal adults, equally distributed equivalent income adults. And we show that in the table that we're seeing there. So what we have is the weights we use for each age group in the population. We have the normal population, thank you, and we have the equivalent adults. All right, so we have the building blocks, so let's forge ahead. And therefore, we have the some of the demographics and so forth from the ESRD population. So we would have had to transform that population as well using our weights, etc. So we have transformed the general population and the population of patients with ESRD. I'll skip there. All right. So this is the table we looked at a little while ago, where we looked at what happens in terms of calculating the index for that. And based on the results of the building blocks that I just talked about, what we ended up having is a general population of homogeneous equivalent adults, each with a mean health utility score of 0.87. That's a general population. And they would have generated actual GDP in 2010 of 132 billion. The estimated potential GDP for that year was 145 billion, with a gap of 12 million. So then now we also have an ESRD population of homogeneous equivalent adults with a mean utility of 0.73. So we see the difference between the general population and the population. They're lower down on the scale, away from 1. And therefore, what we do is to apply that logic where we measure the deviation away from potential income and the deviation away from our perfect utility score. And we plot our graph because we have 3 data points there, our 0 point, where we have no income, and 0, the lowest point on our health utility index. We have the point for the general population and the point for the population with ESRD. And we are able then to solve, based on our scale, for 0.73, I believe it was, for the ESRD population. And what we did from our line equation, we are able to solve for that. And that figure will actually tell us what the intangible cost of ESRD is for an equivalent adult. And what we did is to arrive at a per capita, an equivalent adult per capita GDP, for an ESRD patient of $94,000 plus. And with the population, the total population, the equivalent adult population, that's the general population of 115,000 per capita, we have a difference between the general population and the population with ESRD of $21,000 per person, which is the equivalent, this is the intangible cost of ESRD per equivalent adult. And this allows us then to estimate the intangible cost of ESRD in Trinidad and Tobago, and that was estimated at TT $14.4 million for the year 2010. What we are saying too is that this is equivalent to about 18% of individual income, so it means that the value of the intangible cost is considerable to the individual. What the methodology does is to help us then to go further as we look at other NCDs, NCDs being the greatest cause of morbidity and mortality in our country and in fact in the region, and making the relevant adjustments for comorbidities, etc., we would be able to apply this methodology to a group of NCDs and be able to actually estimate the intangible cost of NCDs in the country and in the region and see how that can impact on our GDP. So this is where the research is going towards, so I thank you for your attention.